I think we'll make a start then. I think people will still keep on joining us, but I just want to make sure that we try and keep to time if we can, because I know everybody's diaries are very busy at the moment. But just to say welcome to today's seminar, I'm absolutely delighted to have been asked to chair today's session. For those of you who don't know me, my name is Professor Deborah Bick. I'm Professor of Maternal Health in Warwick Clinical Trials Unit. And I'm delighted to be introducing today's speaker. I've spent the last 25 years researching into maternal health, including maternal mental health, looking at aspects of perinatal depression. And I know how vital it is to explore issues relevant to maternal health for the mums, for their children, and also more latterly, we know there's much greater impact for the fathers as well. So I'm delighted today to welcome Dr. Bibilola Oladeji from the University of Ibadan, who is a senior lecturer, head of department and consultant psychiatrist in the Department of Psychiatry in the College of Medicine at the University of Ibadan. And she leads both an academic and a clinical department. Her main interest is in psychiatric epidemiology and psychiatry, and she has a passion for increasing coverage for mental health care and working on studies to explore physical and mental health care. And in the role that she's played, she's trained hundreds of frontline healthcare providers to identify and provide evidence affecting implications of mental health. So a very, very fantastic CV, and I'm delighted to welcome you today. And we are very much looking forward to hearing your talk on tackling perinatal depression in resource-poor settings, lessons from Nigeria. Thank you very much.
Thank you so much for having me. Yeah, I hope my slides have come up now.
Yes, that's fine. Okay. We can see them very clearly. Thanks.
Okay, thank you. So I would like to appreciate the organizers, Professor Bick and Abby, for facilitating this meeting and inviting me to speak on tackling perinatal depression in resource-poor settings and to speak to our lessons from the work we've been doing here in Nigeria. So this is the outline to my talk. So I'll start by looking at perinatal depression in low and middle income countries with a focus on Nigeria. And I'll speak briefly about the healthcare system and resources available for mental health care in Nigeria. And I'll look at what are some of the things that are in place for service integration for perinatal mental health and speak to our experience with working in integrating service, and then also to speak to where we think we want to go from here. So prenatal studies have shown that perinatal depression is more common in low and middle income countries compared to the high income countries. But this recent systematic review and meta-analysis by Woody in 2017 actually was able to demonstrate that the rates are significantly higher in low and middle income countries compared to high income countries. The overall prevalence from of studies in low and middle income countries from Woody's and meta-analysis was 13.4% for low and middle income countries and 11.4% for high income countries. And then looking at the different periods, in the antenatal period, it was 19.2% for low and middle income countries, but 9.2% for HICs. And in the postnatal period, 18.7% compared to 9.5%. One thing that this meta-analysis noted was that the rates seem to vary significantly by the identification method, that symptom scales kind of give significantly higher rates compared to diagnostic instruments. And that also played out in some of the studies that have been done here in Nigeria. The perinatal, the prevalence in Nigeria is between 8.1 and 33.3%, and the identification tools seem to have played a part. Studies using the EPDS, that is the Edinburgh Postnatal Depression Scale, found between 10.7 and 22.9%. Studies using the HADS generally find kind of like higher rates of like 30%. But when you come down to just women that have diagnosis, that meet the diagnostic criteria, the rates are about around 8%. And studies from Nigeria show that younger women are at higher risk for perinatal depression. In our study, the risk for depression in the adolescents that were captured in that study was almost 3 times that of the older women. Women who are single, divorced, or separated. And those who felt that they didn't have adequate social support were at increased risk for perinatal depression. And perinatal depression has been associated with negative infant outcomes. And this includes the fact that women with perinatal depression tend to stop breastfeeding their babies early, and their babies have poorer growth rates, and they have more episodes of diarrhea and other childhood infections. And generally worldwide, women with perinatal depression are not usually identified, which is why um, in most settings, professional societies and policymakers recommend that the frontline providers to women in the perinatal period should screen for depression and other mental health problems using a validated tool. Well, while this has become almost routine in many high income countries, for the low and middle income countries, this is hardly the case. There are very few and scattered programs of integrated care for perinatal mental health problems. Just to give a background of the resources available for mental health in Nigeria, the resources are quite scarce, and the little available resources are also inequitably distributed. Most of the specialists, that is most of the psychiatrists that are in Nigeria, are more likely to practice in the large tertiary hospitals like the University College Hospital where I work, and other big psychiatric hospitals that are located in urban centers all over the country, which means most of the services for psychiatric care in Nigeria is actually in urban centers with a lot of the rural areas and suburban areas kind of neglected. If we have less than 300 psychiatrists currently practicing in Nigeria, which means the population to psychiatry ratio, the psychiatrist population should be about 1 to 750,000. And for the psychiatric nurse is not also too different, like 1 to 100,000. And this results in a very huge treatment gap for mental health problems generally in Nigeria. So this slide just shows the our healthcare system in Nigeria. So we have the primary healthcare system, the secondary and the tertiary, and these various levels of healthcare system are kind of governed by different levels of our tier system of government administration. So we expect that most patients would actually enter the healthcare system through the primary healthcare clinics, and which is from where referrals are made to other levels of healthcare. And in Nigeria, just like what I've just stated, the primary healthcare centers are not likely to have any mental health care going on. Most of mental health care available will be at the tertiary hospitals. So studies have demonstrated that using a task sharing approach is what usually would work in helping to improve coverage for mental health problems in low resource settings. And the key element is having the non-mental health specialist provide care for the common mental disorders, and then the few available specialists provide training, support, and supervision, because we know that training is not enough to enable the frontline providers to deliver care. They also need ongoing support and supervision to sustain the care, and also for the specialist to be available to accept referrals for the complex cases and for patients that have more serious mental disorders. So as looking at what we have available in Nigeria that can facilitate service integration, especially focusing on perinatal mental health care, we have a national policy on mental health, and that policy recommends that mental health care is integrated into the healthcare system at the primary, secondary, and the tertiary level. And also another enabler is that the mental health is actually a component, supposed to be a component of our primary healthcare system service delivery. But we know in practice that there's no mental health care going on at the primary healthcare level, because the primary care providers do not have the training or the resources to deliver care for those with mental health problems. Another thing that could enable service integration, especially for prenatal care, is that in Southwest Nigeria, we practice in Oyo State, which is the highlighted part. Up to 90% of women register for antenatal care. And most of these women will register at the primary care level, that is the maternal and child health care clinics. And screening tools, they are available and they've been validated. The EPDS, for example, has been validated for use in the Nigerian healthcare system. And we also know that tackling perinatal depression in women does not really require specialist mental health care. A lot of studies have shown that if you have frontline healthcare workers which are non-physician workers trained to deliver care for prenatal depression. In most instances, it is quite effective. And so for us in our unit, we chose to start at the primary maternal and child healthcare clinics. The frontline, just to know that the frontline providers at that level are mostly not physicians. We have the community health extension workers, that's one cadre of healthcare workers at that level. They have like 3 years post-high school training. Community health extension officers, they'd have additional training after their true training, or some nurse midwives also go for the community health officers training. So these are the level of healthcare workers mostly at that level. And in Oyo State where we practice, we have one general physician who is designated the medical officer of health, who kind of oversees all the entire work across like 10 to 15 clinics which are present in each local government. So we started with this study, the Expanding Care for Perinatal Women with Depression, or the Exponate study. The protocol was published in 2015 in BMC Psychiatry. And all these findings around perinatal care was what informed how we designed these studies. So for the study, we adopted a steps care task sharing model. And we had a 2-arm cluster randomized control trial, which we conducted in 29 primary maternal and child healthcare clinics here in Oyo State. And we had 2 arms, what we described as the high intensity or the stepped care intervention arm, and our low intensity enhanced usual care arm. Just to speak briefly to that, women that were between 16 and 28 weeks of gestational age were screened with depression. So those who have a score of 12 or more on the EPDS, and then after further questioning by the primary healthcare workers, are diagnosed with moderate to severe depression, are the ones that take part. So in the clinics that are randomized into the low intensity arm, because usual care for mental disorders in primary care is actually no care. So what we did was to train them using the World Health Organization Mental Health Gap Action Intervention Guide to be able to diagnose depression and also offer simple psychosocial interventions based on what the MH gap IG provides for. So for those in the low intensity arm, that is all they got. And we did not specify number of visits, but for the high intensity arm, we expected that the women will have weekly sessions in the first instance, additional sessions depending on the severity of depression. And also depending on the severity of depression, for those who have EPDS scores of greater than 18, for example, or had suicidal ideation, the primary care worker was expected to contact the physician for review of that patient. And depending on if the physician feels the patient needed specialist care, they could consult the psychiatrist. And that is at the first level. Then if the woman still does not recover after the first 8 weeks, then the woman goes on to have additional sessions until she delivers her baby. 6 weeks after delivering her baby, she's screened again. So depending on how her score on the EPDS, she has additional sessions. This is what is shown on this slide. So just to speak to our training, so that the primary care workers, since most of them did not really have prior experience with delivering care for mental health problems, so we had training sessions for them, and we normally have like between 20 and 30 healthcare workers in a training session, nothing more than that, so that we first start with lectures, and then they are divided into groups of 3 to 4 for role plays. And the role plays just use case scenarios that we have specially developed to facilitate them practicing how to diagnose depression by asking the questions using the MH gap, and also to enable them practice these different psychosocial interventions that they're expected to provide for the patient. So the content of the training basically included prenatal depression, looking at the signs and the symptoms, how to make the diagnosis, the risk factors, the consequences. And then we now specifically train them on the interventions that they're supposed to be carrying out, which I'll speak to in a later slide. And then also how to identify women that need additional consultation, either from the primary care physician or referral to psychiatric services. We also develop training materials For both arms, we gave them this abridged MH gap IG, which is what is shown in that picture that they're holding. It helps them to ask questions and then also the kind of care to provide for the patient. And then we also give them patient record books. For the high intensity arm, the record books had details of the women's visit. But for the low intensity arm, it was just the books were similarly designed so that the two arms can be similar except for the interventions that the patients were supposed to be given. So the record books were given to them and then treatment manuals with an accompanied chart task for the providers. And we also provided patient information booklet that told the patients about prenatal depression. We called our patient information booklet in Yoruba Iwe Iyanju, a book of encouragement, because it tells them what prenatal depression is and how to take care of it. So in terms of the interventions for the unusual care group, as detailed in the MHCAP IG, they had psychoeducation, and then the providers were supposed to help them to tackle psychosocial problems, just to counsel the women, and then to follow up the women, even though we didn't tell them how many visits to get. But for the step care arm, the interventions were structured. So at each session, the the primary care providers actually had specific tasks and assignments that they were supposed to walk the women through, depending on what the session was about. So the interventions we used included psychoeducation, behavioral activation, problem-solving treatment, and then to also emphasize parenting skills. So what did we find? In that study, we screened a total of 9,352 women who registered for antenatal care with the EPDS. The screening was done by trained research staff, and out of the women, 8.4%, that's 796 of them, had a diagnosis of moderate to severe depression. After screening, the primary care providers asked questions based on the MH gap and determined which women had actually met the diagnostic criteria for depression. So the rate was 8.4%. 686 of these women provided consent, and that's about 90 something percent, and 536 were able to follow up about 80% of them till their babies were 1 year old. We can read more of this study in the publication in the British Journal of Psychiatry with this title. Just to speak to the findings, which is what is briefly highlighted here, the primary outcome was recovery from depression, that is EPDF score 6 or below at 6 months. What we found was that 77% of the women in the step care arm had recovered, and 66% from the enhanced usual care arm, which the difference wasn't that significant. And also for for most of the other findings, the difference between the two arms was not that significant. The main significant finding was in terms of the baby's care. The women from the high intensity arm were more likely to have breastfed their babies exclusively for 6 months compared to the other arm. And then they also had better outcomes in our infant, and we had some infant outcomes which were better in the the step care arm compared to the other arm. So the lessons we took away from that study is that the primary care workers can deliver interventions with good fidelity for women with perinatal depression, and that for most of the women, all they needed was the psychosocial interventions delivered by the primary healthcare providers. None of the women had to go on medication, and only 3% of the women required additional consultation from either the primary care physician or the psychiatrist. So the simple evidence-based interventions which we used in the low intensity or the enhanced visual care arm was effective for treating depression. And so the next question we wanted to answer was, how can we now effectively integrate care for prenatal depression into routine primary maternal and child health care service in a sustainable way? So we needed to find out what would be the best and sustainable way to deliver training to these frontline healthcare providers. Using specialists to deliver training might not be that feasible because the specialists are few, and having to now do that across Oyo State and across the entire Nigeria might be better to actually find a more sustainable way to deliver that training. And in this last study, we were doing the identification as in the screen of depression. So we needed to see, can primary care providers all actually both identify depression and also provide the psychosocial treatment that the women require? And then if they are going to do that, what level of support and supervision will they need for them to routinely deliver care for prenatal depression, and also to look at what are some of the barriers and facilitators that they can identify for them to routinely deliver this care. So that study that is just, we're just rounding up, the scaling up care for prenatal depression, and is a hybrid study with a before and after design. Before the commencement, we actually carried out some formative evaluation to look at what exactly is the current structure in terms of delivering care, and what are some of the things that we can tap on as resources at that level to kind of bring about treatment for prenatal depression. And we also developed training manuals, which is what is shown in this picture. Sorry, the intervention and training manuals. This is the intervention manual, not the training manual. So what we did was to try out a cascade training format. So we identified senior level primary healthcare workers who can serve as trainers to the other frontline healthcare workers. So we developed a training manual which contained all our training materials, which we gave to these senior level primary care providers during their training. So we identified the physicians. As I mentioned, there's one physician in each local government. Then the physician, in addition to 2 or 3 other senior level providers, which could be senior nurse midwives, community health officers, or the senior CHUs, they were the ones that we trained. And we actually trained about 44 of them. But based on our interactions with them and our assessments, we felt that 11 of them were kind of very good, and then they had more experience, and those were the ones that we used to train the frontline providers. So we trained in all about 200 primary healthcare workers. We sat in with the trainers during those trainings. And as I mentioned earlier, one-off training is not enough to get providers to routinely deliver this care. So we organized the refresher training 6 months after the initial training. This refresher training was also delivered by the senior providers that did the initial training. And in addition to the refresher training, we got the trainers to also provide supportive supervision visits to all the clinics in which we were working. So to kind of assess how effective this is, we recruited 2 cohorts of women, one before we trained the providers and the other cohort of women after the training. And we also randomized half of the clinics to use the patient health questionnaire, the 2-item patient health questionnaire, to routinely screen all the women as they were registering for antenatal care to see whether this was something that primary care providers could do to aid their being able to identify perinatal depression. So the primary healthcare workers use these 2 items, the Yoruba version, just ask 2 questions about whether the woman was depressed or whether the woman was feeling hopeless. And we looked at it because we wanted to know how well they're able to identify depression. So we had trained research staff sit in clinic. After the patients had been assessed by the primary care workers, then they were screened with EPDS by the research staff in the clinic. And then the research staff also went to check the patient's record notes in the clinic to see whether there was any documentation of depression diagnosis, or maybe they wrote any treatment plan related to mental health in the patient's record book. So what did we find? When the senior primary care level providers trained the frontline providers, we found that the knowledge of depression we had pre-test instruments that we used. The knowledge of depression significantly improved immediately following the training. And from this chart, we can see that they were able to retain that knowledge when we reassessed that 6 months. There was a slight decay, but the scores on the instrument was still relatively high. That's 6 months after their training. And then in terms of identification of depression, before our program started, the primary care providers were only able to identify about 2% of the women presenting to the clinic with mental health problems, with depression specifically, before the training. And then after we trained them, for the clinics that were not screening with PHQ2, After the initial training, the identification rate went up to 4%. And then after the refresher training and the addition of the without the PHQ2, after the refresher training and supportive supervision, their identification rates went up to 12%. But compare that to the clinics that were using the PHQ2. After the initial training with PHQ2, the identification was 11%. And then after the refresher training and supportive supervision, their rate went up to 50%. So from this, we see that there's still some challenges. Even though the rate of education had gone up, this was still not optimal. And we observed that there might actually be some system level factors that are at work here. The primary care providers and it's part of some of the things that they complained about during our training and during the formative evaluation was that they had to do so many things. So they were kind of overburdened, that they had to, render care for child health problems, render care for communicable and non-communicable diseases. And so they were not really well motivated to take on additional responsibility. And one other thing that we observed was that because mental health indicators are not in the health information system, they did not feel any obligation to kind of render mental health care because it's not something that they have to report. Unlike other things that they do, they need to report the number of pregnant women that they register, they need to report the number of deliveries that they take, report the number of immunizations. So mental health indicators were not included. So they really had no no strong reason to continue rendering the care. So that was one of the things where we felt that might be responsible for some part of they are not really identifying the women. And then the resources for ongoing support and supervision is not available. The senior level providers can only do the supportive supervision when we provide them with the support to do it. And in terms of being able to sustain this, government ownership will be key, and these are some of the things that we know we need to still work on. And then the service disruption from the COVID-19 also have affected the primary care workers delivering these services. So looking at it, the way forward, we would continue our ongoing advocacy and networking with the appropriate government agencies. In Oyo State, for example, we've been able to have the senior level officials in the Ministry of Health enter into a memorandum of understanding with us about helping them to build mental health services through the primary care in the state. Even though, well, that is where it is for now. We've really not had any commitment, strong commitment from the government about how to implement this. And then we're also exploring integration of treatment for perinatal mental health problems at other levels of care. And we know that the same way that we have deployed for primary care may not work because the resources at the different levels are different. For example, in the secondary level of care, frontline antenatal care is provided by the nurse midwives with the doctor supervising each clinic. And like in tertiary center in UCH where we work, for example, frontline care is actually delivered by the doctors, either the house officers or the resident doctors, with the nurse midwives playing more of a supportive role and consultants kind of supervising the practice. So what works in primary care may not necessarily be what we have to do in the secondary care. So we're exploring different modalities. In the secondary care level, which we are started from now, we're exploring the use of mobile phones to deliver the psychosocial interventions by the nurse midwives to the patient using the phone and to see whether that might be something that is viable to consider in the natal clinics of the general hospitals as they are ongoing. The My Petals project that is ongoing at that level. So we're waiting to see how effective that is. And we're also working on development of a specialized unit that can serve as a referral center for severe disorders. And as of now, we do not have facilities for mother baby admission, and we're seeking to work collaboratively with our O&G department to develop a workable model for service integration at the tertiary level, which is one of the reasons why I've invited colleagues from the O&G department to be a part of this meeting this afternoon. So just for some acknowledgement, I would like to acknowledge my colleagues and our team from the World Health Organization Collaborative Center for Training and Research in Mental Health and Substance Use Disorders, headed by Professor Yegureji, and my colleagues, Dr. Abdul Malik, Dr. Lola Kola, Mrs. Oyekon. And then pictured with us in this group photograph are some of the primary healthcare workers that we trained who served as trainers for the other primary healthcare workers. So we have a few of the physicians and the senior nurse midwives and community health officers as part of this. And I would also like to acknowledge our collaborators and funders. The Exponate study was funded by the Grand Challenges Canada, while the Spectra study was funded by a consortium of funders from Canada through the IDRC, and the Petals, the ongoing project, is being sponsored by the Fogarty International Center of the NIH. Thank you very much for your attention.
Thank you, Bibilola. That was absolutely brilliant. We've got plenty of time for questions, and I think Lola and Abby are going to keep an eye on the questions and feed them through. But what was so fascinating for me from your talk was there's so many parallels with us here in the UK trying to sort our mental health services. Because we have been so concerned that they're not being asked about mental health, that there's not really appropriate referral pathways for women when they are exhibiting mental health problems. And we've also had a similar lack of places like maternal infant units for women who have got very severe mental health problems. It's getting better, but we've still got a long way to go. And I was fascinated by the challenges that you spoke about as well, because again, we know exactly the same. We have the same issues in terms of trying to get interventions that appear to be useful, appear to be targeting women appropriately. They rolled out, they seem to work well, but as soon as you step back from the research point, it all goes back to what it was before. So I think there's some amazing parallels there. So thank you so much, that was really useful. Can I take the first question? Lola, do you want people to read, do you want to read out, or do you want people to sort of come in and unmute themselves to ask the questions?
I can actually unmute people, so if they raise their hand, I can unmute them.
Lovely. So do people want to do that? I think there was just something in the comment box there I saw flash up.
And otherwise, anybody who sends questions and answers, yes, Abby or I can read them out. So, yes, Phil Irving just sent a message to say, really excellent work and very pertinent in so many places around the world. So a compliment rather than a question, but very nice to hear.
Thank you.
Further questions?
While we're waiting for people to come through, can I just ask, are you getting much support from the policy makers? We struggled a bit to get maternal mental health back on the agenda, and I think what frightened our policymakers so much was that in our confidential inquiries into maternal deaths, deaths from suicide were one of the biggest causes of maternal death, and I think that really opened up, the sort of policy and the funders of our health service to we need to do something about this. Are you getting much support on the ground with your work, and recognizing mental health issues need to be identified and managed appropriately?
Okay, thank you for that excellent question. And the thing is, well, it's interesting for me to hear that we're not alone in this struggle with trying to get things from research to policy. One of the interesting things, the last study that I mentioned, the Spectra, part of what the funders tried to do was to also have policymakers as part of the research team. So the list of research, the team that I presented, we have 3 co-PIs. We have the researcher co-PI here in Nigeria, we have another researcher co-PI from Canada, and then we have a policymaker co-PI, who at the time was actually the director of primary health care for Oyo State. He's been moved now to somewhere else, so somebody else has taken up that post. So the funders also funded health policy research organizations, as they call them, to kind of help us to navigate working with policymakers. And for us, they funded the West Africa organization, the West Africa Health Organization, the WAHO, as that. And the WAHO was kind of at the front line with organizing meetings between us and the policymakers. So we've had several of those meetings, but there's really, even though we've had several of those meetings, there's really no strong commitment from the policymaker end about what the way forward will be. But in Oyo State where we work, we've also had part of our advocacy efforts has paid off in that finally they've created for us a mental health desk officer. So who we believe that we'll be able to work with to see how we can, kind of translate this really into something that becomes a routine. Another thing that we have done, because we use the frontline providers, the senior ones to train, so which means we already have a pool of trainers in the system that the government can deploy at any time that they are ready to take on, adding to building on this work. So getting the policymakers have been difficult, but we've been at every level trying to engage them for them to understand what is going on. The greatest breakthrough that I think we had with one of the policymakers in our state was they have this National Council of Health meetings that involves all the policymakers from every state. And our project was one that our state policymaker decided to showcase that there's something going on in mental health in Oyo State. So I think that was one of the greatest breakthroughs that we had in terms of that.
Yeah, it's so important, isn't it? Thank you. That was very helpful.
Hello, we've got another question from Phil. She was saying that women often feel very isolated if they express anything other than positive feelings about their pregnancy. Is there this stigma in Nigeria? And if there is, have you found a way to tackle this in the wider community so that women can express these feelings more freely?
Yes, it's the same in Nigeria. People, not just even women, people generally don't want to talk about mental health. But it seems that of recent, with a lot of advocacy, we've been able to do that. And then like here, we had this with the training of the providers. For example, let me use the project that is ongoing in the secondary level hospitals as an example. When I started and I interacted with the nurse midwives that were in their natal clinics, they were like, there's nothing like mental health problems here. We don't see any women that have this problem. So in talking to them, I told them that some of the women that we generally have problems with, that we think they're non-cooperative, it's not that they're non-cooperative, it's because they have mental health issues that is affecting them. That's why you think they're not cooperating with coming for antenatal clinic. They don't cooperate, they don't listen to you when you are giving your health talks. So after the training that they got back, they now started identifying these women, and it became very easy for them to ask these questions. And one interesting thing that happened, one of the patients that had been on this project before, and she had perinatal depression, she got over it with intervention from the nurse midwives. After she got well, she was able to identify a few women in her community that she felt, no, this person has the same problem that I had. And then she dragged them to the hospital, that come and see my providers. They took care of me, so I know they can take care of you too. So those are some of the things I'll be using to break the ice. And then the last World Maternal Mental Health Day, we had like an NGO that is also interested in maternal mental health, and she was able to, the leader of that team was able to, she's a journalist, so she was able to get us into a lot of media houses to talk about it. And since then, we've been getting calls from different people. So we're kind of trying to use as much advocacy as we can to break the ice.
That was a really lovely answer. We've got another question in the chat from Nekan Osiemi to ask, I might have missed it, but could you mention some of the psychosocial interventions that were implemented in Exponate?
Okay, we use them, the things that have been found to work for women with perinatal depression include treatment that is as simple as psychoeducation. The women have just having that understanding that what you have is depression and you are not alone in this, and it's something that do happen to people and help is available. So psychoeducation was one. The other thing was activity shared lane. We know that women with depression generally have lost interest. They don't want to do things that they normally enjoy doing or things that they had to do. So the primary care workers work with them to schedule specific activities that they would do over the next week before their next appointment. And part of the follow-up visit will be to kind of get a feedback from the women and to work with the women to kind of score themselves on how well they have done with those activities they were supposed to do. And the kind of work with them is so specific, and they choose whatever day of the week they're going to do the activity and fix a specific time and actually fix a specific activity to improve their chances of succeeding in doing it. And we also use problem-solving treatment because we know that when there are psychosocial problems, it keeps the depression on. So we help the primary care providers were trained to kind of help the women to identify the specific problems that that they're being faced with, and then to identify, working with the women to brainstorm, find solutions to it, weigh the solutions to see what can work, and then for the women to go and implement it, and also to come back and give a feedback on how well they have done, how well that has helped them in improving their depression and all that. So those were the specific ones that we used in the Exponate study.
Another question, but we've got two more actually, so I'll do Helena's first and then I'll come to Emma's. So with Helena, she asks, is there any opportunity to follow up the babies or children for a longer period of time, say 5 years, to provide evidence of the importance of treating maternal depression?
Well, for now, we don't have that opportunity yet, but we can see, we have their records, because before we started this second project, we actually were able to, then we have, okay, which I didn't go into, we also have an ongoing project that is targeting adolescents, because we find that the adolescents were more affected with perinatal depression compared to the older women, and it also impacted their babies. We have the paper published on that in Frontier Psychiatry. So we were able to secure funding as part of the other project to actually have more intensive interventions for the adolescent group. And before we started that program, we went back to look for some of the adolescents that were in the former study to bring them together to kind of brainstorm with us that what do they think was helpful for them when they went through our program, and what did they think that would have been helpful for them as adolescents having perinatal depression at that time. So we have records to be able to reach them, but the problem will be the funding to be able to reach that many people, for us to be able to follow up for that length of time. So if we're able to secure funding, might be something that will be worth exploring.
So Emma's question touches on stigma, returning to the idea of stigma. So you talked about stigma in response to Phil's question, but asking about when women go back to their communities, if they have a diagnosis, does that mean that stigma is then attached to those women?
Okay. What we try to do is to avoid labeling in our program. So often even when they're doing the problem solving treatment, we know that, from my experience, once you say you have a mental health problem, then the women themselves close up. So what we say is to tell them to have the Yoruba interpretation of it, which just means you've been feeling sad, you've been feeling low. So that is all we let them understand, rather than actually putting a label of that that is the depression or feeling sad is actually a mental health problem. So we try not to let that be at the forefront of our discussions with these women, so that, to reduce the stigma and then to break that barrier of their coming. And another thing that we try to do is to encourage the primary healthcare workers to see these women outside of busy clinics, so that, when the women come, sometimes they come with other relatives and family members, and they're all sitting together in that open area in the clinic. So if you are singling out some of them for that, they might feel stigmatized. So we try to just encourage the primary healthcare workers that there are days when you don't really have clinic. There are days when your clinics are not so busy. That's the time to tell these women to come back for the psychosocial intervention sessions, so that, it's not that they get labeled by other people that are there. So we try to, work around the stigma and the labeling.
Can I just coming in there, Bibilola, we've had a real problem with that in the UK, because a lot of women wouldn't report mental health problems because of the stigma, and because they were so frightened their babies may be taken off them. And we found that as a real barrier sometimes to women, say admitting that they, don't feel happy, they feel, very low in their pregnancies or after their pregnancies. So, stigma is an issue that we, again, are having to sort of think about here, really, and how we manage and how we talk to women, how we talk to their partners. Just fascinating, really.
I think it follows quite nicely onto Paul's question. Paul Sutcliffe's question is, how engaged are fathers in your interventions for women? Do you feel they have an important part to play? Do you think paternal mental health is something that needs to be tackled in Nigeria? And would fathers be receptive to disclosing their problems and getting help?
Interesting questions. I actually had a colleague that did some work on paternal depression, and he also actually found that the rates of depression was actually also high in the fathers, even though not as high as that for the women. So in our program, what we try to do is sometimes, and it's part of the training that we give the primary care providers, that sometimes you might have to bring in the man. So sometimes we tell them, let your husband accompany you to clinic, and then they also psychoeducate the man, so that the man too can understand that what your wife has is not that she's become lazy all of a sudden, is because she's not feeling well. That's why she's like this. And this sickness is something that can happen to anybody, even you. so that this woman needs support. So sometimes we do that for the men that are willing to come. They try to invite them. Not all of them will come, but the few that come, the primary health care workers are trained. Now we know that paternal depression is something that needs to be tackled, but it's not something that we've started working on yet.
Thank you. And one more question here, which is from Sue Wan Hee. She asks, we have seen an exponential use of technology due to the pandemic. I have an impression that mobile phone is rather common everywhere now. Can they be used as part of the intervention, e.g. support group, advices, resources, while maintaining the women's anonymity?
Well, I'm not sure about the groups, because we need to look at it. For most of men that we're working with in the primary care level, they only have basic phones available, which are just phones that can receive calls and text messages. And for quite a number of them, they're not that literate enough to be able to even handle text messaging. So the part that we have really used, we've tried to use voice messages, trying to kind of remind them that you and your primary care provider discussed some issues. We hope that you are attending to the things you promised to do, because, from the problem solving treatment and the behavioral activation have homework tasks. So we've used voice messages to kind of remind women. And then I mentioned that I have another ongoing study, which is at the antenatal care, where I'm comparing two groups of clinics. A group of clinic are delivering the same care, the psychosocial interventions, over the mobile phone, while the other group are doing it in face-to-face sessions. And one thing that was interesting was that the primary care, the nurse midwives were actually very engaged with that, and they actually loved the idea that the fact that they could actually be more flexible with scheduling sessions outside of even the time when they are actually physically present in the clinic. So that was something that was working. And another thing is some of the patients that the nurse midwives have started engaging before the coronavirus outbreak, they were able to continue engaging them even when they couldn't come to clinic using the mobile phone intervention. So it's something that is workable and something that we're already actually exploring the use of.
So you have some more thanks. You have thanks from Paul Sutcliffe, thank you. And you have a thank you from Helena, both for answering their questions. I'm not sure if there are any other questions.
Can I just ask another question? It's just so interesting, so fascinating. One of the things that we're also moving towards now is realizing that we have to look at the whole woman. And what we're finding is a lot of women who've had physical injury, birth injury, may develop PTSD or, may develop anxiety and all sorts of other things. And we've not been very good at looking at women, as a whole. You either got mental health problems or you've got a physical health problem. So we're just sort of trying to start work to look at the comorbidity. And I'm just wondering if there's anything, that if you're planning anything in the future, or if you're collecting data on women's physical health as well as their mental health and well-being. Because I think that's the shift that we may see here going forward is looking at the whole woman if we can.
That, I guess, is one of the things that I'm planning to work with colleagues in our obstetrics and gynecology department, which is a more specialized service. And is one of the things that I think would be important going forward. One of Nekon that asked the question, actually his studies, he's been looking at anxiety disorders in women in primary care, and then the kind of the family dynamics and how that affects all that. And the study is quite interesting because it's found that the women also have high rates of anxiety, which is not something that we have been looking at. We focus more on depression than anxiety. And then also to look in terms of integrating care, we know that in addition to women that have mental health from perinatal period, infertility is also another issue. There is also have a massive and the cancers, increased risk for mental disorders. And in planning these services with our O&G team, I think is something that I'm looking to and hoping for a complete service integration for a start, since we're both in the same facility, but as of now, we all work in our silos. I work in my psychiatric clinic, they work in their O&G clinic. So I'm thinking to see how we can actually marry the services.
Yes, it's very much, we're trying to think about how we can do much better MDT, multidisciplinary, and get everybody around the table. We haven't cracked it yet, but it's certainly something that we've really got to try and tackle. Thanks, Lola. So are there any more questions, Lola, or?
No more that I can see in the chat.
Okay, thank you. Abby, do you want to come in? Is there anything you want to ask?
Thank you very much. That was a very interesting one and very, very interesting. And I just look forward to doing more work on perinatal mental health myself. One of the things you mentioned, Dr. Bibilola, is about the fact that when you did one of the studies, I think is the Spectra, where the frontline workers screened the patients, I mean, more than 2,000 of them.
Mm-hmm.
And then you had physician diagnosis for more than 700 women. I just wonder if you have a record of how many were picked up by the screening tool, so we can see how different that was. You know, you did mention about the fact that screening tools.
Let me, well, we're in the process of still analyzing the data, but what we discovered was that the screening tool actually helped the primary care providers to identify women that need, so that what we told them, screen with PHQ2, any woman that, and you know what they said was very fascinating, was that they actually eventually learn the questions off by heart. So at the time when they're doing the physical examination of the baby, of the women, that's when they said that they could ask that so it doesn't take them time to ask just those 2 questions. And any woman that responds positively to any of them, they now sit them down and ask further questions to see whether the woman actually has depression. So what we discover in the clinics that are using that instrument, the identification is actually much better than the clinics that were not, because what we do is after they screen, after they have seen the women, they will now have trained research staff in the clinic who now screen the women with EPDS and ask a few more questions to see whether the woman actually meets the duration and the severity criteria based on DSM-4 criteria for depression. And then we now compare the numbers that we have to the numbers that the primary care providers identified, looking back into their records. That's how we got those figures of the 50%, the 4% that were being identified. So the screening tool is actually very helpful, and it's not something that is difficult for them to do.
Great. Thank you very much.
Well, I think, Lola, if there are no more questions in the sort of chat room, we're nearly at the end of our hour anyway. So can I just say a massive thank you to Dr. Bibilola. That was absolutely fantastic, really interesting. And as I say, I'm struck by so many parallels between what we're facing and what we're trying to do, and the challenges and the barriers to try and improve mental health. And it's just really, really interesting to hear your work. So on behalf of the whole team and department, can I just say a massive thank you for your time today. We've all really enjoyed it. And, you know, fingers crossed that we will be able to collaborate and meet up at some point in the future once all this pandemic is rolled and seen its course. But thank you so much, Bibilola, and on behalf of everybody, thank you very much for what you've done for us. Thank you.
Thank you so much for having me, and I look forward to the collaborations. Probably after soon that the COVID will be over soon, so that we can get back.
Fingers crossed. Thank you very much.
Thank you.
Bye-bye.
Bye.